More on this for an expert take. We're joined by Dr. Sherry Glied, who's Dean and Professor of Public Service at New York University. She was also former Assistant Secretary for Planning and Evaluation with the U.S. Department of Health and Human Services during Obama's first term. Dr. Sherry Glied joins us now. Good morning, Doctor.
Good morning.
Thanks very much for joining us on the program. Hope you're having a good day.
Very good.
So what was your reaction when you first saw that President Trump, who had campaigned on getting rid of Obamacare, was finally getting some action, at least in as much as he could, from an executive order?
Well, I think given the failures of the Republican Congress to repeal Obamacare, they've been trying to do that since about March. I think most people who are in this world were trying to think about how is Trump going to try and do this using the tools that he has at his disposal that don't require him going to Congress. So that's what he's trying to do now. The executive order asks his departments, the Department of Labor, the Department of Health and Human Services, to consider developing new regulations governing the health insurance market. So it's a long way off until something will actually happen. He is just indicating effectively what direction he'd like to go.
So this is, if anything, just really a minor political gesture to make it clear that he's not backing off Obamacare reform, but this doesn't really do all that much. It
certainly doesn't do anything yet. The regulations that will be written by the Department of Labor and the Department of Health and Human Services could conceivably do somewhat more. They can't really demolish the whole plan, but they could make it a little bit harder to maintain the risk pools. So right now, because Obamacare continues to be a private insurance market plan, there's no central insurance system like in Canada. In order to keep it going, insurance companies have to be willing to play in that market, and the risk pool has to be maintained. People have to continue to buy the coverage that everyone else is buying. This could shake that up some. But it really will depend on how the regulations are written.
Now, during the campaign, even though the president had the candidate Trump had a lot of sort of venom towards Obamacare and looked like he was fully going after it, he also talked about it almost in a keep the best and get rid of the rest attitude. As someone who was in the U.S. Department of Health while this was being rolled out, do you think there's some merit to the idea that, look, this was a huge undertaking that was done and there's going to be a bunch of unintended consequences, so there are a few things that should maybe be changed about it?
Oh, I think that with any program that's large, and especially a healthcare program, you need to be constantly looking at it and thinking about ways to improve it. There's no doubt about that. However, as the president said when he got into this late in February or March, he said, no one knew that healthcare could be so complicated. It's not that easy to tweak these programs. You have to really be thinking about all the consequences down the line. That's actually one of the challenges of running the healthcare program using private companies the way the U.S. is continuing to do.
And from that perspective, I mean, I'm sure you attend sort of many conferences and many papers are written and so forth, looking and detailing the nuances of Obamacare. Is there a perspective in sort of the health planning community that there can be changes made by President Trump that actually are happy ones? I mean, for some people it's seen as, he's just going to be this insurgent who lobs a whole grenade at the whole thing. But are you optimistic that there can be good tweaks in the months and years ahead?
I think that there are some things that could be done. The law envisions that states could actually experiment with their programs some, and that hasn't happened very much, but there are some interest in states in doing that, and the administration, the Department of Health and Human Services could help states experiment and consider variants on the program that might work better for some people, and also that might be more responsive to the particular situations of different U.S. states. Of course, different states in the U.S. have such different healthcare marketplaces and different demographies that, you might think that what might work in a very densely populated state like, say, Rhode Island might be a different plan than would work in, say, North Dakota.
We're joined now by Dr. Sherry Glied, who's Dean and Professor of Public Service at New York University and a former Assistant Secretary at the U.S. Department of Health and Human Services. Dr. Glied, I remember when Obamacare first came out, I had some friends who were in Manhattan and going through, I think, law school and other schools, and they were quite left-leaning individuals and Obama supporters, and then they opened up their documents and found that their premiums were going up, and they were kind of upset and frustrated and so forth. I have a very naive question about about basic math to put to you, but is there a way that the Obamacare can sort of continue in terms of giving coverage to a whole wider swath of people without people's premiums going up so much?
Well, of course, you could do something more like what happens in Canada, and you could raise taxes and pay for the plan using taxes more, or you could do like what Canada does and regulate the prices much more than the U.S. does. But as long as you're going to actually, I mean, the fundamental problem is that the cost of healthcare per person in the United States is about twice as high as the cost of healthcare per person in Canada. That's not the health insurance, that's the care itself. If you're going to get people to pay for that, somehow that money has to come from somewhere.
Yeah, it seems to be a challenging situation in the U.S. where various different corporate entities providing health services can, kind of sort of bill whatever they want, whereas we put caps on a lot of these services. And while our doctors are sole proprietors, they are incorporated, they're not government employees, there is, as you point out, a cap to the amount that they can bill. Is there some talk of integrating a variant of that to the U.S. medical system?
Well, of course, on the left, the Bernie Sanders people are pushing for a single-payer healthcare system. That is to move to something much more similar to Canada, where it's not the amount they can bill, but the actual prices at which they bill are established by the government. In the United States, that's only true for the Medicare program. And the Medicaid program, for most people with private health insurance, the prices that their doctors and hospitals bill are not established centrally, and they could bill whatever they like. Or whatever they can get an insurance company to negotiate with them. So there is interest in moving to a system with more price controls, to moving to a system with more government taxation. We could debate whether that would be a good idea or not.
And before I let you go, Dr. Glied, so we say we got the Bernie Sanders people who just want, a single-payer system, which is a total reform again, and then Republicans who want to be done with the whole Obamacare thing, but they actually seem to lack ideas. That's what the headlines suggest to me. Is there any hope for just kind of optimistic workaday changes that hopefully everyone can be happy with?
I think there is always hope. I think that there are small tweaks to the plan that people have suggested. I do think that if we are concerned about the premiums that middle-class people pay, we're going to have to take a really serious look in the United States about why our healthcare costs are so high to begin with. Because we can't really, middle-class people, one way or another, are going to pretty much pay the cost of their health care if they pay it through taxes or they pay it through premiums or something. So it's really that underlying cost that's really the issue here. And in the U.S., it's just a very high number.
Dr. Glied, thanks very much for joining us with your expert take on this.
Thank you.
Sherry Glied is Dean and Professor of Public Service at New York University, and she's a former Assistant Secretary for Planning and Evaluation with the U.S. Department of Health in the first term of the Obama administration.